To move your arm, your brain relies on a highly specialized neural network. This is the brachial plexus, formed by specific spinal nerves. It begins right at the base of the neck, emerging from 5 exact spinal nerve roots: C5, C6, C7, C8, and T1. These 5 roots are responsible for delivering every electrical impulse needed for motor control and sensory feedback down the entire length of the upper limb. To manage that massive data flow, the plexus organizes into a strictly logical hierarchy. From proximal to distal, nerves merge and split through roots, trunks, divisions, cords, and branches. Medical students lock down this sequence using the standard mnemonic, "Randy Travis drinks cold beer." Memorizing this sequence serves a highly practical purpose. This 5-tier architecture is the exact blueprint neurologists use to diagnose nerve palsies and anesthesiologists use to execute regional nerve blocks. The architecture begins deep in the neck. The initial nerve roots emerge directly from the cervical spinal cord and pass outward between the anterior and middle scalene muscles. These 5 roots, C5 through T1, are the bedrock of the structure. Before merging, they send off 2 immediate branches, the dorsal scapular nerve from C5 and the long thoracic nerve from C5, C6, and C7. The long thoracic nerve supplies the serratus anterior muscle. If a patient suffers an injury to this specific pathway, they lose the ability to stabilize the shoulder blade against the rib cage, resulting in a distinct clinical sign known as a winged scapula. Moving laterally, the 5 roots combine into 3 trunks. C5 and C6 merge into the upper trunk. C7 becomes the middle trunk. C8 and T1 form the lower trunk. Here, the upper trunk releases the suprascapular nerve, responsible for shoulder abduction. When trauma, like a birth injury or severe shoulder traction, damages the C5 and C6 roots, it paralyzes muscles fed by the upper trunk. The patient's arm hangs adducted, internally rotated, with an extended elbow. Clinicians call this Erb's palsy, or the waiter's tip posture. Because roots and upper trunks lie superficially in the neck, anesthesiologists target this exact site for an interscalene block, numbing the shoulder completely for surgery. By pinpointing this proximal architecture, clinicians can isolate and address upper limb deficits before the neural pathways even cross the collarbone. As the plexus travels distally, it descends behind the clavicle. Each of the 3 trunks divides into an anterior and posterior pathway, yielding 6 distinct segments. The 3 anterior divisions supply the flexor compartments of the arm. Conversely, the 3 posterior divisions exclusively supply the extensor compartments. This dense, tightly packed bundle of divisions tucked behind the collarbone provides an ideal target zone for the supraclavicular block, which yields heavy anesthesia for general upper limb surgery. These divisions act as a mandatory anatomical checkpoint. It is here that the body biologically segregates the nerve signals for pulling inward from the signals for reaching outward. The nerves now enter the axilla, or armpit. At this stage, the neural architecture organizes itself around a single vascular structure, the axillary artery. The 6 divisions recombine into 3 cords, named for their position around the artery.
Anterior divisions of upper and middle trunks form the lateral cord. The lower anterior division becomes the medial cord. All 3 posterior divisions form the posterior cord. Excessive upward traction on the arm can tear the lower roots, C8 and T1, that feed into the medial cord. This causes Klumpke's palsy, leaving a patient with weak intrinsic hand muscles and a characteristic claw hand. To numb the lower arm without affecting the shoulder, anesthesiologists use an infraclavicular block, injecting medication directly around these cords as they surround the artery. Because cord nomenclature is tied strictly to arterial proximity, the blood vessels act as physical compasses, guiding needles and scalpels safely through the nervous system. Leaving the axilla and traveling down the arm, the 3 cords finally divide into the network's distal endpoints, 5 major terminal branches. First, the lateral cord gives rise to the musculocutaneous nerve, carrying root values C5 through C7. It provides the motor supply to the biceps brachii for elbow flexion and handles sensory input for the lateral forearm. The posterior cord gives off the axillary nerve. It powers the deltoid for shoulder abduction, making it highly vulnerable to damage during fractures of the surgical neck of the humerus. The posterior cord continues as the thick radial nerve,
driving the extensor muscles of the elbow, wrist, and fingers. If crushed against the humerus, the extensors fail, leaving the patient with a severely drooping wrist. Both the lateral and medial cords contribute fibers to create the median nerve. This nerve controls most of the forearm's flexors and enables thumb opposition, while gathering sensory data from the lateral palm. When the median nerve becomes compressed inside the tight bony passage of the wrist, it causes the numbness and pain characteristic of carpal tunnel syndrome. Finally, the medial cord continues down to form the ulnar nerve. It dictates fine finger movements by controlling the intrinsic muscles of the hand. Damage here results in a tight, curled claw hand deformity. Anesthesiologists isolate these specific terminal branches during an axillary block to perform complex hand and wrist surgeries while the patient is fully awake. These 5 terminal branches receive abstract electrical impulses from the cervical spine and convert them into the precise mechanical dexterity of the human hand. Viewed in its entirety, the brachial plexus is a contiguous, fully constructed unit running from the spine to the fingertips. The architecture follows a strict sequence: 5 roots, 3 trunks, 6 divisions, 3 cords, and 5 terminal branches. By checking a patient's hand for specific motor or sensory deficits, neurologists can reverse engineer the neural circuitry to locate an exact point of injury in the neck or shoulder. Anesthesiologists use these same tiers to deploy highly localized nerve blocks, mathematically turning off sensation in specific segments of the arm while leaving the rest completely functional. With the brachial plexus, anatomy dictates exactly what is clinically possible. Mastering this structural logic provides the only safe method to diagnose, anesthetize, and repair the human upper limb.